Nationally speaking, and this, sorry, in the United States, I need to be a little bit more mindful, close to a third to 40% of the population will report hypersensitivity disorders, whether you're talking about anaphylaxis, asthma, food intolerances causing food allergic reactions in the gut, headache syndromes, anaphylaxis. And unfortunately, the incidence and the prevalence of these disorders are growing. At the center of immediate hypersensitivity reactions is the mast cell. And this is a cell that was recognized back in the 1800s. It was the Germans who made some new fashion dyes of the era. Basically took those chemicals that make the new fashion colors, threw it on living tissue, and they were able to light up these cells. And since then, these cells have been implicated in plenty of disorders affecting every organ system possible. And the reason for that is mast cells are situated in every single organ system. And so, in some ways, you now need to envision what does a hive or a flushing incident look like in the brain, or the gut, or the bones. And then what would be that manifestation of that symptom? So anybody who has a mast cell disorder or basically dysregulated function of the mast cells can present with upper airway inflammation called rhinitis. They can present with headache syndromes and also neurocognitive defects, which commonly is referred to as brain fog, anaphylaxis, food allergy. And food allergy can present with onset of diarrhea, constipation, bloating, failure to thrive, leaky gut syndrome where you are not absorbing micronutrients. Interstitial cystitis was recently renamed by neurologists in New York as hypersensitivity cystitis, where food products, once they're broken down, end up irritating the lining and actually recruiting in mast cells as well. Irritable bowel syndrome, and I don't know if too many orthopedic surgeons will admit to this or rheumatologists, but there are individuals whose joints get significantly worse after being exposed to foods that they're sensitive to, called allergic arthritis as well. Now, mast cells elucidate a lot of chemicals, but I think the most famous molecule is histamine. And there is overlap between the term histamine intolerance versus mast cells. But just focusing on the histamine action alone, histamine operates on 4 different receptors, and depending on the expression of these receptors in different organ systems, when histamine is released, it can cause issues in the brain, in the heart, in the airways, in blood vessels. Dr. Pasinki just mentioned the fact that if you release histamine, it can make your POTS worse because it makes the blood vessels leaky. The second histamine receptor, most of you might be familiar with Pepcid and Zantac and Tagamet. That is a histamine blocking agent, which actually impacts the function not only in the gastrointestinal tract, but in the heart, in the brain, adipose tissue or fat cells. We even have histamine 3 receptors and 4 receptors, and we have medication that is readily available for the H1 receptor and the H2 receptor. And actually and I defer to the psychiatrist who just spoke a little while ago, but one of the agents that a lot of allergists use, neurologists use, gastroenterologists use include tricyclic agents, which actually work on the histamine receptors, both the first, second, and third receptor. So it's interesting how a medication that was readily used by psychiatry for many years until SSRIs essentially came onto the block, has now been adopted by other specialties who these individuals seem to have mast cell disorders that the tricyclic agents just need to help as well. Now, as I just said before, mast cells contain a lot of different chemicals. Histamine is just one. And I have to say that mast cell disorder is much bigger than histamine intolerance. This is a figure from a New England Journal of Medicine article this past year by Dr. Theorides, Dr. Aiken, and Dr. Vellet, talking about the diagnosis and management of mast cell activation disorders. And I'd like to highlight a couple of the chemicals besides histamine that we use to measure when trying to diagnose a mast cell activation disorder. One, which I'm sure if you're getting evaluated for mast cell activation disorder, the doctor who ordered it, tryptase says, well, your tryptase is normal, so you don't have mast cell activation disorder. So my tidbit there to tell the doctor who ordered that is tryptase is not released in all reactions. The most obvious one is food-induced anaphylaxis. You can test for tryptase all day long, and an individual who's anaphylaxed to the food will never have an increase in tryptase. So now the question is, did that person not anaphylax, or you're just asking the wrong test? So it's really important to try to look at other chemicals that these mast cells release. Matter of fact, one of the older articles on anaphylaxis in the New England Journal of Medicine identified kinase as a molecule that gets released during anaphylaxis. And interestingly enough, both kinase and tryptase act on collagen. And some recent research by Dr. Milner down at the National Institutes of Health identified individuals that have mutations in their tryptase molecule have hyperextensibility. So there's individuals that have issues with their collagen, and it's not an intrinsic collagen defect or an enzyme that is particularly associated with collagen. It is a molecule that's derived from the mast cell. And actually, I posed this question a couple of years ago. Is it a possibility that one form of hyperextensibility is actually due to release of chemicals from a cell that's situated in every organ system that also has connective tissue? Other molecules that we use to look at are prostaglandins and leukotrienes, and as you can see, depending on which mast cell subset is activated, following some type of an exposure or trigger, and a trigger can be allergic, it can be physiologic, meaning I personally have had cold-induced urticaria and angioedema for 20 years. I can look for an antibody to cold all day long, that's not going to pop up. It is a clinical diagnosis for the most part. So you have to kind of take a step back and understand that our bodies aren't, gastroenterology and neurology and neurosurgery and immunology. It's an organ system where all the tissues are cross-talking. And depending on that crosstalk, you might end up being symptomatic. So just to give you an idea of how many different ways mast cells can misbehave, and then the different chemicals that get released, this is somewhat of a busy slide. However, I want to emphasize the fact that even when it comes to anaphylaxis, you can present with different symptoms. Generally speaking, 40% of individuals that have anaphylaxis have no skin symptoms whatsoever. And one of the symptoms that a lot of people report is change in mentation. One of the audience members asked a question about change in their ability to speak. We noticed that several people report, at least 25% of people report change in their neurocognitive function and mood disorders when they have an anaphylactic event as well. You can have gastrointestinal distress, you can have bone pain. Matter of fact, one way we diagnosed one mast cell activation disorder, I had a gentleman who came to my office a couple of years ago. He's a 32-year-old with osteoporosis, and he had mastocytosis. So the mast cells were overactive in his bone, causing increased bone turnover. And that was the way we found out that he had a clonal mast cell activation disorder. Now, mast cells, I would say since the 1950s and 60s, really have been shown to be kind of pigeonholed into allergic disorders, meaning that IgE, which is part of the adaptive immune system, you end up producing an antibody to whether it's a stinging insect, or a cat, or pollen, or dust, or mold, and then that molecule sits on the mast cells in the tissue. It's kind of like your local police officer in your neighborhood has a mugshot. And that mugshot will identify somebody who was causing trouble there before, and they'll be able to readily recognize this danger and quell it a lot faster. And I use this slide to show that when you're looking for mast cell activation disorders, not only are you looking for potentially an increased number of mast cells, but you also want to make sure that the mast cells are of a certain shape. Here in the lower slide, let's see if I can work the pointer. Oops, sorry. Well, In the lower slide, where we have the cells that have been stained with H&E, the red cells are antibodies that are targeted to a molecule on mast cells, and they're perfectly round. Thank you. Let me just pass this. Perfectly round. When mast cells are spindle-shaped or clumped together, these guys really like to be isolated. They don't like to be too close to each other. That suggests that you might have a mast cell disorder as well. So in order to understand how mast cells become disordered or dysregulated, I think you need a kind of an idea about how mast cells work in the first place. And I really consider mast cells to be kind of like local peacekeepers. Just like your police force, someone joins the police academy, they get their basic training, and then they get their marching orders. One person, I want to use New York City as an example. Somebody gets assigned to Upper East Side near, the mayor's place of residence, and somebody else gets assigned to 125th Street and Fifth Avenue, which has a lot of other different types of activities going on. And that police officer has to learn how to work that neighborhood. Same thing with mast cells. They get their marching orders. You go to the brain, you go to the small intestine, you go to the bottom of the foot, you go to the spleen, you go to the liver, and you need to figure out how to best serve that local neighborhood the best you can. So it is the connective tissue and the surrounding elements in that local environment that educate the mast cell on how it's supposed to meet the needs of that neighborhood. So there is really indirect evidence, because I have to say there's not that much information about connective tissue disorders talking to mast cells and back and forth, but there have been some isolated reports showing that individuals that have connective tissue disorders, mast cells seem to be more upregulated or dysregulated, and I'll briefly touch on that in a few minutes. So, as I mentioned before, hypersensitivity disorders have been on the rise since the 1950s, and I have to tell you, growing up in the Bronx in the 70s and 80s, I hardly heard of anybody with asthma or food allergies. Zyrtec was what? And now it's an epidemic. We find that mast cells have been, and depending on what journal you read, mast cells are implicated in lots of different organ systems. You have mood disorders, dermatitis, asthma, bone health, neuropathies. Someone had asked a question earlier about connective tissue disorders and multiple sclerosis. I can tell you, if you have an immune-mediated disorder affecting an organ system, and you already have, so that means your mast cells are going to be participating as well, because the antibodies that attack the nerves, the effector cell that gets recruited in, are part of the effector cells that get recruited in our mast cells as well. And I've seen individuals that have MS, and if they have IgE to tree pollen, their symptoms get worse in the spring. So this, again, kind of reflects the crosstalk that's going on in the tissue that may exacerbate whatever pre-existing condition you do have. So, generally speaking, there are two ways your mast cells can become dysregulated. And again, using that analogy of the police officers or your police force, the form of mast cell activation disorder that most healthcare providers are familiar with, which is rare, is mastocytosis. This suggests that one of the molecules in the mast cell has sustained a mutation, and basically it's like a permanent on switch. So these cells keep on proliferating and proliferating, and they might proliferate slowly, or they might proliferate much more aggressively. And basically you have an increased burden of your soldiers, kind of like what's going on in Turkey right now, where you have all this police force who are armed to the teeth, and it doesn't take much for something non-specific to cause those mast cells to degranulate and release their chemicals. What's more common, and is completely underdiagnosed and undertreated, are individuals that have what's called non-clonal or non-proliferative disorders, meaning that your mast cells are actually doing their job, they're just getting bad orders. And the bad orders can come in different forms, and I'll get into that in a couple of slides. There's been ongoing discussion of the 6 or 7 people that I know that are participating in care of individuals that have suspected mast cell activation disorders. that there have been 4 criteria that have been put forth to see whether or not mast cells are contributing to your symptoms. The first thing really is you need to get a good history. Are you having signs and symptoms worrisome for mast cells misbehaving more than usual? And it has to affect at least 2 organ systems. Are you itching and getting headaches? Are you having bloating and getting flushing episodes? Do you find that your mood is changing? And I have to tell you, I have one patient who was diagnosed with postpartum depression 30 years ago. And she was put on every psychiatric med you can think of. So the postpartum depression got put into depression and anxiety and attention deficit disorder. And she's been on medications for 20 years plus. And I don't know if her adverse reactions to the medications or her undiagnosed immune disorder, but I have to tell you, once you identified her immune disorder, she was able to get off most of the medications and is feeling much better. Then, what a lot of the allergy immunology specialists use is to see whether or not you actually respond to medications that target the mast cell specifically. And I'm going to focus, so what we use to diagnose mast cell activation disorder comes under the umbrella of the treatments that we use to treat mast cell activation disorders. But here I'm mostly going to focus on what we use to try to diagnose the mast cell activation disorder, and afterwards I'm happy to address some other allopathic as well as complementary interventions that have been known to be very helpful, including mindful meditation, traditional Chinese herbal therapy, acupuncture, acupressure, exercise. Actually, in my office, I had the pleasure of Stacey Davis joining my practice, who is a psychosocial worker, and her stress management has been instrumental in helping the patients kind of get a plan to try to help themselves as well. Then, after you get the story and see how well you responded to treatments, I had one young lady who was diagnosed. She's a competitive athlete, and unfortunately this happens to a lot of women more than men, or young ladies compared to young gentlemen, was diagnosed with an eating disorder. And they thought she was avoiding food because she wanted to maintain a competitive weight, as opposed to the fact that the food was making her sick and she was avoiding the foodstuffs. Interestingly enough, they put her into a residential facility and took away any privileges, as she did not eat her 2,000 calories of food. And she ended up losing 10 pounds on top of her, so she went from 125 down to 115, and by the time I met her, she was at 102. So it's really important to kind of listen to the patient, and I know it's very difficult for a lot of healthcare providers, knowing that we have, maybe 15 minutes on a good day if you're in certain medical facilities. But after you get the story and find out how well you respond to medications, it's really important to get some laboratory data to kind of reinforce what you might be suspecting in these individuals that are coming with worrisome disorders that most of them have been suffering for years. As I had shown before, mast cells elucidate a lot of chemicals, and also a lot of the chemicals they elucidate are elucidated by other organ systems or cell populations as well. But the markers that are specific for mast cells that are commercially available include serum and urine histamine, prostaglandin levels, tryptase, and then it's important to kind of biopsy the organ system that bothers you the most. And the issue here is, even with the biopsies, we don't know what the normal levels are, just because not that many studies have been done to say, okay, what's the normal levels of mast cells that are found in the small intestine, or what's the normal number of mast cells that are found in the tethered cord, or what's the normal level of mast cells that are found in the bladder. And then, after you've asked those 3 questions, it is really important. I have to tell you, mast cell disorders don't ride by themselves. And also, all that wheezes is an asthma, all that causes rednesses in your skin isn't necessarily a mast cell activation disorder. It's really important to rule out other disorders that may be contributing to your symptoms. So, talking about the first criteria, episodic signs and symptoms consistent with mast cell activation dysfunction. You need to ask yourself, and it's amazing how we all kind of push through our symptoms, whether it's fatigue. I have had a patient push through repeated fainting spells, feeling that's all she was known. I had another patient, and I kept on asking, are you itchy, are you itchy? And she said no. And then when I finally put her on medication, she's like, yeah, actually I was itchy, I didn't realize that. And here's the thing about itch. Itch from mast cells gets worse at night. So if you want to exacerbate a sleeping disorder, have a pruritic disorder that interferes with your body's ability to rest. Of the chemicals you can see here, again, not only histamine is an issue, 2-necrosis factor. And I have to tell you, when it comes to mast cell activation disorders, we have individuals that either have problems with inability to lose weight, and then we have individuals who have an inability to gain weight. And they're rather suspicious of chemicals like 2-necrosis factor and interleukin-6, which recruit in inflammatory processes that basically overtax your body's ability. You're basically stealing away from your normal housekeeping duties as well. This is a picture just showing all the different things that can happen with anaphylaxis. And I have to tell you, when it comes to immune-mediated disorders, if you want to talk about a diagnosis that gets missed constantly in the emergency department, that's anaphylaxis. And that's because we only have one test, which is tryptase, which you can never get in the emergency department because they don't know what to do with it, nor do they know how to order it. And also, just the way we teach anaphylaxis. And the one point I want to make here is anaphylaxis isn't you're fine and then you can't breathe. I kind of treat anaphylaxis like the earthquake scale. You can have a grade 1 where you're itchy all over, or you can have a grade 5 where you need to call 911 10 minutes ago, where you actually have a cardiovascular respiratory compromise on everything in between. So if you're having sudden onset of fainting, and this is where it can overlap with other disorders, especially Dr. Sinke had just mentioned the issue about myocardial syncope as well. It's really kind of important to see whether or not you might be having a mast cell disorder contributing to your symptoms, whether it's throat closing or this sensation that you're feeling up, or if you're having neurocognitive impairment. I don't know if anybody has issues with when they ingest certain foods or certain climates, they feel that their ability to think or remember or their mood changes. For women going in or out of their menses, that can also impact their ability to have dysregulated mast cell populations as well. Epigastric distress is very common in mast cell disorders, and that can present with bloating, diarrhea, constipation, failure to thrive as well. There have been a few papers looking at case series of patients that have been diagnosed with a clonal mast cell activation disorder. To the left is individuals that were diagnosed with mastocytosis, and it's a little bit skewed because these individuals have skin lesions that force them to go to a doctor that has expertise in mastocytosis. And so you can see that skin lesions are the presenting symptoms, but then after gastrointestinal distress, it's neuropsychiatric symptoms. Headache syndromes, mood disorders, sleep disorders, ability to think clearly or remember what you had thought about. And then more recently, this paper was done by a group in Boston where they looked at 20 individuals that came to an IBS clinic and asked them, and here's a doctor who's thinking outside of the box, do you have any of the symptoms besides your GI symptoms? And when you ask them, they're like, yeah, actually, I've had anaphylaxis, or I've been treated for asthma. But interestingly enough, number 3 is neuropsychiatric as well. And unfortunately, we don't have any quick tests to evaluate for neuropsychiatric changes that are implemented in offices where you can measure whether or not somebody's having changes because they have mast cell disorders. So there are plenty of triggers that can cause mast cells to release, either suddenly degranulate. You have classic IgE-mediated disorders or allergic disorders. The usual suspects in the food groups are soy, gluten, nuts, seafood, milk, cow's milk, and egg, as well as shellfish. And then in the non-allergic triggers, we have a lot of individuals that have occupational exposures, whether they're chemical fumes, medications will do it, Synthetic fibers, some individuals have, and one way you can diagnose mast cell activation disorder in individuals is whether or not they have any large local reactions to insect bites, especially mosquitoes. With IgE triggers, again, you've seen this substance before, you've made an antibody, it sits on the mast cells, and then when you see it again, there's that mugshot I was talking about, you cause degranulation and release of these chemicals that cause you to become symptomatic. Again, these are the usual food triggers, but there's also common airborne triggers, including pollen, mold, animal dander, and components of dust. In the Bronx, the biggest offender is actually cockroach. And then there are plenty of non-allergic triggers, and I have to tell you, we have a lot of information on IgE-mediated disorders. We have very little information on the crosstalk between nerve fibers and mast cells that may lead to individuals that have cold-induced urticaria, angioedema, or anaphylaxis. We don't know exactly what's happening with some of these chemicals. I've had 2 patients anaphylaxed to Febreze being sprayed in the air. Paint fumes, again, certain fibers that will cause local irritation, depending on where it sits as well. I like this slide because it basically talks about several of the medications that patients receive. I had a patient recently who's had pain syndrome for close to 10 years, and he's on several medications, especially in the opioid family, and I gave him Xolair, which is a molecule that goes after the IgE molecule, preventing mast cells from degranulating, and for the first 3 days in a long time, he was pain-free. He was so pain-free, he stopped his pain medications. So basically, he ended up with withdrawal symptoms, which then forced him to go back into that vicious cycle again. So I have to tell you, this is a team sport and a coordinated effort through lots of different disciplines. It's really important to understand that there's certain medications like non-steroidals. Even though aspirin and ibuprofen could cause mast cell degranulation, we can actually reintroduce it in most patients if they need it, in a way that actually causes the mast cell disorder to get under better control. There are immune-mediated factors that can cause mast cells to degranulate. Again, if you have an autoimmune disorder, including antibodies that go against your own mast cells or the antibody that sits on it, that can cause you to have a chronic mast cell disorder as well. This is kind of just to emphasize the different communication. I was trying to understand what happens in the tissue. When it comes to cells, mast cells can either have direct contact, in this case this is a nerve fiber, or they can secrete chemicals that only talk to nearby nerve fibers, or they can have distant communication. And treatment focuses on interrupting this communication, whether it's up close and personal, or you're blocking the secreted, either blocking secretion or their target on the nerve fibers, and potentially on the surrounding connective tissue as well. There are plenty of mast cell receptors. Mast cells are really designed to identify various substances. And then also there are communications between the nerve fibers and the mast cells, which will cause the mast cells to degranulate. So as I shared with you, I have cold-induced urticaria. We have some people who have pressure. Certain chemicals that get released can also cause mast cells to degranulate. If you have an autoimmune disorder that's kicking out certain types of chemicals like interleukin-33, you can cause mast cells to either increase in number or activity as well. And then you can also see that there are chemicals derived from nerve fibers that can also cause mast cells to become dysregulated. This is just a summary slide showing you all the different ways mast cells can be upset. Mast cells were originally designed to recognize parasites, viruses, certain bacteria, whether or not there's any physical trauma. The communication can happen with nerve fibers, the surrounding connective tissue, or nearby inflammatory issues. But once these cells are activated, depending on what they see, they'll call in whatever necessary help. It's kind of like that police officer again, who, if they see somebody down, you don't need to call in the SWAT team, you need to call an ambulance. If these mast cells see what they think is a parasite, they'll call in eosinophils. If they think it's a bacteria, they'll call in neutrophils. Or they might think they need the job by themselves, so you might not see any infiltrate. You might not see any inflammatory cells whatsoever. And by the way, unless you have special stains for the mast cells, you can't see them. You really need to ask the pathologist. You have to have stains that target the mast cells themselves. Again, lots of different symptoms and signs that are associated with mast cell dysregulation. Medications that are typically associated with mast cell activation disorder to try to get it under control include medications that target histamine, including histamine blockers, and we have H1 blockers such as Benadryl and Zyrtec. We have H2 blockers such as those that are used for reflux, including Tagamet, which is cimetidine or ranitidine and famotidine. Steroids are tried and true. However, some patients can't tolerate certain forms of corticosteroids, and by the way, not all medications work the same in individual patients, so it's really important to tailor the therapy. Tricyclic agents actually work on the first, second, and third histamine receptors. Leukotriene blockade, most of you know montelukast or singular. There are 2 other medications that also work on that pathway as well. Mast cell stabilizers, including catodafin, as well as cromolyn. And then there is this molecule that's been around for 13 years. This is Xolair, or omalizumab. It has been indicated in this country for 13 years for the treatment of asthma, and 2 years ago it just got indicated for chronic hives and urticaria. And then as far as laboratory testing, again, you can check your serum tryptase, and sometimes you need to check the serum tryptase more than one time. So if it goes up 2 plus 20%, that's indicative of you having a mast cell activation disorder. You have prostaglandin or histamines in the urine that might indicate that your mast cells are overactive. You may have abnormal looking mast cells in the tissue, and you need to stain them with these molecules to identify whether or not they're chronically activated or not. And then to light up the mast cells themselves, you either have to use a CD117 antibody or a c-KIT antibody, which is a major receptor on mast cells as well. So you think you might have mast cell activation disorder, and I'm not going to go through all these conditions, but these are conditions that mast cells are involved, but not necessarily a primary mast cell activation disorder. And it's really important to sort that out because there are other treatment modalities and diagnostic modalities that need to be identified to make sure that there's not another condition that's contributing to your symptoms as well. So, what do we know about mast cell activation disorder in individuals that have a connective tissue disorder? Not much. I have to tell you, these are complaints that I've had from patients before who come through my office. And again, 2 symptoms, and two symptoms that are involved. And common manifestations are gastrointestinal distress, skin symptoms, bone metabolism issues. And then when you start talking to them, they'll, and here's the thing, asthma is undiagnosed or underdiagnosed in this country, so I will do a different breathing test to make sure that they don't have lower airway involvement as well. Again, there are 2 flavors of mast cell activation disorder. This says, I'm sorry, after Dr. Chopra made a very valid point. You can have mast cell, you have a subset of mast cells that have just gone rogue. So this is mastocytosis or monoclonal mast cell activation disorder. But the most common form of mast cell activation disorder is secondary or non-proliferative, meaning again, these mast cells are misbehaving, and there is some other comorbid disorder that are causing the mast cells to misbehave. Oh, what did I do? All right, so if you have any of these symptoms, it might be important to ask whether or not your mast cells are misbehaving. How's that? 10 minutes, right? Again, I had one patient who said, I felt better after I took Benadryl. There you go. There's one medication that's helpful for calming down mast cell activation disorder, and then what evidence do you have to support it? Primary mast cell activation disorder, again, mastocytosis, you have a mutation in the c-KIT gene, and monoclonal mast cell activation disorder, you also have a sustained mutation in the c-KIT gene, but it doesn't cause such a profound syndrome as mastocytosis. This is what's more common, and what I look for when people come to my office is I'm trying to understand, do you have these other things going on that may be contributing to your mast cells being dysregulated? And for the folks here, these physical urticarias, this is a conversation between your mast cells and your surrounding connective tissue. And then, if I can't find this, and I can't find this, I'm an idiot, I can't figure out what's going on, so you get tossed into the idiopathic. Again, lots of different disorders. Mast cell activation disorder, mastocytosis means you got too many mast cells running around. Secondary or idiopathic mast activation disorder means you have the same number of mast cells, they're just in overdrive, they're doing overtime because of some other disorder. Again, this is a child that came to me. This is an isolated mastocytoma, so if you biopsy this, he has more than 80 mast cells in that one lesion. This is a more diffuse version of mastocytosis as well. This is a young lady who came in for allergy testing. As you can see, she has a little bit of hypermobility in her elbows. But more importantly, you see this is skin testing. Her reactions were much more prominent when I skin tested her. So there's, again, some type of conversation that's going on between the mast cells when they get triggered in individuals that have connective tissue disorders. This is just looking at pathology, so I'll save that for the pathologists in the classroom. This is another mastocytoma, and you can see, remember I was saying that mast cells don't like being clustered? This is what it looks like under the microscope, and that shouldn't be. It should only be like one or two in the field. Lots of different cells crosstalk with the mast cells, whether or not they're nerve fibers, lymphocytes in the area, fibroblasts, as well as eosinophils. I want to identify that if you have chronic Hy's or urticaria, it's really important to identify whether or not you've developed an autoimmune response attacking your mast cells, which would mean you have now a mast cell activation disorder as well. I have to tell you, and this is kind of an issue about healthcare, if you have a nose problem, you go to an ENT. If you have a skin problem, you go to a dermatologist. If you have a headache, you go to a neurologist. Everybody kind of sticks to their own little corner of the sandbox and doesn't think outside of the box. So it's really important to kind of think, well, I've tried all these things, not getting any better. You need somebody who's going to take a step back and a little bit more of a thorough history. Okay. So I just wanted to, I'm going to fast forward a little bit. I have to tell you, my first introduction to connective tissue disorders outside of my internal medicine board exams many moons ago, I went to Dr. Google, and I came up with this veterinarian who started talking about whether or not Ehlers-Danlos was the key to understanding connective tissue disorders. And for me, it's more along the lines of, is Ehlers-Danlos the key to understand how mast cells become dysregulated? And he started talking, and as Dr. Henderson had alluded to, there are certain breeds that have a tendency to have connective tissue disorders. Interestingly enough, those breeds also have food sensitivities, leaky gut syndrome, eczema. And so there's something going on, again, with this crosstalk between the connective tissue as well as the immune cells that are situated in the connective tissue, that being mast cells and also dendritic cells. This is a very old article, I shouldn't say old because I'm dating myself. Dr. Castori, a lovely geneticist out of Italy, put this article together looking at different data trying to understand what's associated with joint hypermobility syndrome. And I'll leave that to the other working group on defining Ehlers-Danlos hypermobility versus benign joint hypermobility versus joint hypermobility syndrome. However, he talks about immune dysregulation in addition to chronic pain syndromes, chronic fatigue, but he doesn't elaborate what that immune dysregulation is. And that's essentially where we are right now when it comes to trying to understand what does mast cells do in individuals that have a connective tissue disorder such as EDS or joint hypermobility syndrome. Again, there are lots of chemicals that can crosstalk with the surrounding connective tissue. There was one paper coming out of Siberia that identified individuals who had an eye surgery, and interestingly enough, the individuals that were found to have a form of connective tissue disorder, the number of mast cells were the same, kinase was upregulated in those patients. And again, Dr. Milner identified individuals that have a mutation in the tryptase molecule. He identified this in 3 generations in several families. If you have an elevated tryptase, you are at increased risk for having hyperextensibility as well. So again, the questions that we need to address is what's going on between all the cells that are sitting in your different organ systems. You know, what's the crosstalk between the mast cells and the fibroblasts and the nerve fibers? And is this conversation, you know, quiet, or is it the Tower of Babel, causing you to be quite symptomatic? So going forward, what we really need to do is try to understand this crosstalk. Are these cells And I have to tell you, I've seen individuals that have mastocytosis, and yes, there are issues with their connective tissue. And even in that little boy that I pointed out to you, who has mastocytosis in his skin, he has respiratory issues, he has gut issues, but they're not increased number of mast cells that are in the tissue. It's just that the mast cells in his skin are secreting factors that are upregulating his other organ systems as well. But we need to understand whether or not abnormal collagen metabolism is causing mast cell dysregulation, or is mast cell dysregulation causing abnormal collagen metabolism. And, you know, it's a question of which is the chicken and the egg, or is it both the chicken and the egg that's causing the patients having those issues? I have to tell you, this has been a journey, and I am extremely grateful to this foundation, as well as my colleagues. And of course, all of you. Thank you.
Hi, Dr. Maitland. Thank you for all that you do for us. I know it's helped me a lot to learn a lot from you. One of the things you mentioned in the beginning is you work with about 6 other doctors on this. Can you share who they are? Because I can't find one in Texas, that's for sure. They look at, I have a third eyeball or something when I go and tell them, explain what's going on. They want to give me Benadryl and go home. I'm actually allergic to Benadryl and they don't believe me.
I'm happy, just come up to me afterwards. I'm happy to, I do work with a couple of physicians in Texas. San Antonio is probably going to be your best bet because they have a great allergy immunology program. There are 2 allergy immunology specialists that I know that might be helpful for you as well. Thank you. Hello.
You mentioned that mast cells can be involved with interstitial cystitis. Is there a test that can be done to determine if that's the cause of the symptoms?
Oh, sure. Urologists have no problems doing procedures. You need to do a biopsy. Take a picture of the wall. Another thing is you can do a 24-hour urine collection looking for elevated urine histamine as well as elevated prostaglandin D2 or prostaglandin 11 beta F2 alpha. So there are standard tests that are validated, but you can either look directly at the tissue and tell the pathologist to light up the mast cells with those stains.
Thank you.
You're welcome.
Hi, I suffer from allergies to fragrances. In fact, 3 of the 4 most prominently affected by EDS in my EDS side of the family are highly allergic to either fragrance or, in my aunt's case, basically everything under the sun. Every time she goes to the doctor, it seems like she finds a new allergy, including the glue that should be used for her pacemaker. I'm just wondering if, well, I live in Inwood and I see you have a practice in not too far from there. I was wondering if I could come over sometime and discuss these.
Well, I have to tell you, there's a special group of providers that are in this room, and we are kind of a little on the overwhelmed side. You're going to have to pardon me. This is really a call to arms. This needs to be addressed by a coordinated center. A multidiscipline team under one roof, where we have neurosurgery, neurology, allergy immunology, GI, psych, everybody. I have to tell you, the reason why I'm saying this is the waiting list to get in to see me is going out to April. And what I can do is I can refer you to 2 other allergy immunology specialists that I know are willing to listen, and they can start the workup, and then they can communicate with me, and I can also work with them. So what I've kind of adopted is, if you can identify a provider that can be your kind of like on the ground healthcare provider, I'm happy to work with that person, just because it really is a coordinated effort that takes a few weeks to kind of sort things out. I mean, even when it comes, somebody just mentioned that they're allergic to Benadryl. You know, sometimes you have to use a different agent. Maybe you have to compound it. Maybe you have to compound it a certain way to make sure you're okay with it. You're talking about chemical sensitivity, and it sounds like your mast cells might be upset and have upregulated or downregulated receptors that recognize those chemicals. There are certain things that can be done to identify what you can take or not take, and also some treatments that may be helpful for you to tolerate when you encounter those airborne chemicals as well.
Thank you very much, but I think I was just more saying, if you're looking for a guinea pig, I'm nearby.
Appreciate you. No, definitely come up to me afterwards, and we'll talk about how we can proceed.
Very good. Thank you.
Hi.
So I, over the last 2 years, have kind of developed a problem where I cannot eat. Anytime I do eat, it feels I either throw up right away, or it feels like, even if I'm eating mashed potatoes, it's like trying to take a Dorito chip and swallow it whole. I don't have problems breathing. I have other reactions that I'll get as far as skin stuff. But as far as the throat, it doesn't feel like it's completely closed. There's no struggle with breathing, and they keep telling me it's probably an allergy, but I've been having a lot of problems getting it pinpointed. And since it seems to be exacerbating, I guess my only fear is does it seem like that kind of reaction could get to the point where there's complete throat closure, where it could cause a problem where I'd have to call, emergency services? I'm sometimes afraid to eat because I'm afraid that could exacerbate to that point.
So I think it's really important to kind of separate out what's going on in your esophagus versus what's going on in your airway. And unfortunately, our body doesn't really discriminate very well regarding certain pain syndromes or difficulty. And so if it's a question of swallowing, I think it's important to start with a gastroenterologist just to make sure there's not any issue with motility with the gut, which can be.
I did have an endoscopy, and everything through the endoscopy came back 100% clear and fine.
Okay, and
so I'm not sure if is that what you were referencing?
Right, and did they do a biopsy to see whether or not there's any issues with?
They did not.
Essentially, the first place to start is with a willing and able gastroenterologist.
Okay.
And if you're willing to come up to me afterwards, and you tell me what part of the country you are, I might be able to point you in the direction of somebody who's shown interest and ability to help.
Okay, thank you very much.
Hi.
Hello.
So you mentioned that the mast cells interact with lymphocytes as well, and I've been having an issue with my 6-year-old who has been having a lot of enlarged abdominal lymph nodes, and with no discernible cause or trigger that cause a lot of pain. And I'm wondering if that could be a possible mast cell involvement.
Mast cells are involved, it's just a question of how much.
Right.
And I have to tell you, when it comes to secondary disorders, if you don't get after the bad rules, the bad laws, the mast cells will come completely under control with the mast cell, directed medications. You have to understand why the lymphocytes are there in the first place. Whether or not this is like a adaptive rheumatological issue. There's been plenty of information showing increased presence of mast cells in the joints of those that have rheumatoid arthritis. And using medications to kind of target the mast cells have been shown to be helpful. I've had individuals who've have been given omalizumab or Xolair for their hives, and their joint problems get better. So it's really important to establish are your mast cells overactive, and if so, why? Thank you.
Question about an article that came out recently about long-term use of antihistamines being linked to Alzheimer's. Is it that we're all doomed to get Alzheimer's anyway, and we're the ones taking the antihistamines, or is it actually the antihistamines?
Actually, it was only one antihistamine that was implicated, and it was a very small study. When it comes to a chronic disorder, period, my approach is I'm going to give you a recommendation. These are the suggestions that I'm making. These are the side effects you need to watch for. And then we modify it based on, and you come back, and we step up as you get worse, and then I think everybody should be given the opportunity to step back. So I'll give you another example. Steroids have been used for years for asthma, but we also know it causes osteoporosis, osteopenia, vocal cord dysfunction, necrosis of the hips. And so, efforts are made to kind of use other treatment modalities besides an antihistamine to try to keep your symptoms under better control. And there are other treatment modalities that are available, and I think the purpose of any provider is to provide you with the different treatment options, and then it really needs to be tailored to you. So if I have somebody who is well controlled on Advair for their asthma, I might recommend Xolair, because Xolair might help keep their asthma under control and make them less dependent on using the Advair. So I really think, and I also work with a lovely woman named Shu-Min Lee, who is an associate professor at Mount Sinai. And I use, she uses traditional Chinese herbal therapy, acupuncture, and acupressure, and has the data to back up how effective it is in certain, hypersensitivity disorders as well. So there are other treatment options available. I think it behooves the person who's taking care of you to explore those options and see what works best for you.
And is there anything to address tumor necrosis factor yet?
Yes, I have to tell you, there are plenty of tumor necrosis inhibitors out there. You see them advertised for psoriasis and rheumatoid arthritis, right? And they're not without their risk factors as well, but you need to identify whether or not TNF is a problem in your condition before you would, employ that type of treatment.
And there's blood work for that?
There is. But it also, again, it almost depends on what your symptoms are and weighing the pros and cons of using those type of treatments.
Hi, Dr. Maitland. Thank you for sharing your expertise with us today. I have yet to be evaluated for mast cell activation syndrome, but I am highly suspicious. In your opinion, could an extreme reaction to red dye 40 in particular be indicative at all of mast cell activation syndrome?
Yes. Okay. The reason why I like those apples. Green ones, not red. No. So understand that some of these food dyes are actually derived from substances that you might not be aware of. Certain dyes are actually derived from insects.
Yes, and petroleum, I hear as well.
Right, so that might be the problem right there.
Okay.
All right. So, and then interestingly enough, when you start talking about it, you're like, oh yeah, I had that reaction to years ago. It's amazing when you start, you're so preoccupied with what you're dealing with now that sometimes it's important to kind of take a step back. And it's really, I really do emphasize to several patients, it's important to kind of keep a diary and your triggers as well, because that kind of, you're my best source of your signs and symptoms, as well as what you tolerate and what you don't tolerate. I don't have one of those tricorders from Star Trek to figure it out. So, this is the next best thing. It's your story.
Thank you.
I have an 8-year-old daughter that I was wondering if it sounds like mast cell. She has a lot of nasal congestion, and now she's having GI problems. But when we did the allergy testing, she came up with nothing. But she's always sounds like she has a cold. And so I was just starting to wonder if that is a direction we could take, because it was nasal congestion now that has turned into stomach ache, nausea, and they're saying acid reflux. So.
Yeah, so this kind of goes back to how many different ways, if you ask that allergist how many different ways you can get hives, they're going to tell you cold and heat and certain chemicals, whether they're derived from medications or foods. So this is a non-IgE mediated mast cell activation disorder, which is another way of saying it's a non-allergic mast cell activation disorder. And the best way to kind of, so I can't tell you how many patients come through, and I had one patient who had chronic GI stuff, chronic respiratory stuff. I was allergist number 6. She wanted me to test her again. I'm like, well, my testing toolbox is not that much different from the other 5 that were before me. I went ahead and got her blood work. Turned out she had a primary immune deficiency. And until we address the primary immune deficiency, your symptoms didn't come under control. I have to tell you, 50% of people that have asthma and sinus issues have problems with salicylates. Have problems with salicylates, aspirin, or aspirin-like substances. And so it's really important to kind of list all the different types of triggers, and that's why I put that slide up so often, is to let you know, mast cells, if your police officer relies on a single mugshot to identify a person who might do some harm in your neighborhood, not a very good police officer, right? Mast cells have toll receptors, estrogen receptors, mechanoreceptors, immunoglobulin receptors, complement receptors, all to kind of survey the entire environment to say good, bad, or indifferent. You need to kind of, and unfortunately we have but so much testing available to just identify what could be potential triggers. But I think it would behoove to just make sure that there are not any other issues that we can identify, and then after that, it's treatment, because the more the mast cells stay on, the more they stay on, and then you start developing further sensitivities.
First of all, I say thank you, and I'm wondering if you could clone yourself and everyone at this table up here for the rest of us. Also, I'm trying to use the technique through, I see Dr. Frank-Romano, Dr. Krasinski, trying to get my outside resources while I've been waiting to get into you. So I'm on the diet, do problem sodium, do ketofen. I'm finding that I'm having a lot more breakthroughs where my mast cell reactions are getting worse. I'll be okay for a while and worse. So I've added Benadryl in regularly. I want to know your thoughts on piling on. And the other thing is that Xolair is coming up now with allergists that I'm trying to see locally, but Blue Cross Blue Shield and a lot of other major insurance companies have decided in the last 6 months to no longer approve it. And is that side effect based, or is that they don't want to spend the money for it as a patient?
First of all, whatever allergist you're working with, they can call me. 1. 2, it's all how you talk to the insurance companies. Now, if it's a question, so Xolair is not inexpensive. It's anywhere from $900 to $2,700 per month, right? But interestingly enough, the insurance companies are willing to pay for that if you have chronic hives. Why is that? How many people who get hives end up in the emergency department? How much does an emergency department visit cost? I mean, why if this keeps on happening, right? And then you're talking about lost time from work, lost time from school, what have you. So if you can get a pre-authorization depending on how the question is put to the insurance company. And I have to tell you, I have yet to have it not approved, as long as you have all your ducks lined up in a row. And also, both the companies that are responsible for that medication have foundations, and I have to tell you, for most medications, there are foundations available where they have grant money to support you using that type of medication. So there's ways of getting that for you, and then typically when it comes to medication like omalizumab, I usually give it 3 months to say yes or no, does it work or not. I have to tell you, sometimes it's like the Jesus effect after the first shot. Other people, I have to use it a little bit longer, or I have to titrate in a certain way that they tolerate it.
What about continual regular use of Benadryl?
I think there are other medications to try to see if it's a little bit more effective. You know, a lot of people have a tendency to use montelukast, but montelukast is the weakest out of that class. A lot of doctors have a tendency to forget that Accolade is out there, and Accolade is a lot more effective than montelukast. And then, just like there are medications for hypertension, you have ACE inhibitors and ARBs. Montelukast and zolpidem work at the level of the receptor, while xylitol works at the level of the enzyme, and it's a lot more effective. Okay?
Thank you so much to Dr. Maitland for all the